Welcome to this session. Our topic now is vaginal intra epithelial lesions. My name is Adeboyega Fawale, Professor and Honorary Consultant, Department of Obstetrics and Gynecology, University of Ilorin, and the University of Ilorin Teaching Hospital, Ilorin, Nigeria. Historically, vaginal cancers are more common in the elderly and the postmenopausal women. If vaginal malignancy is found in younger women, it is etiologically linked to cervical cancer, specifically with regard to the persistence of high-risk HPV infections. Vaginal cancers, although rare, are increasingly being seen in younger women these days owing to the increase in the persistence of the high-risk HPV infections, especially in settings with a high human immunodeficiency virus prevalence. The terminology of precancerous human papillomavirus associated vaginal lesions has changed over time. In 2014, the WHO classification replaced the three-tiered classification used previously, vein 1 to 3, with squamous intra epithelial lesions. This is divided into two categories, low grade and high grade. The low grade is vein 1 may be associated with either low risk or high risk HPV and represents productive or transient infections that may regress. In contrast, the high seal represents transforming high risk infections, previously vein 2 to 3. Our diagnosis many times is colposcopy examination, directed biopsy at mainstays. Directed biopsies. This is from the mainstay of our diagnosis because many times there is no symptom. Typically, the lesions are located along the vaginal ridges, ovoid in shape, could be slightly raised, or they could even have surface spicules. Vein 1 lesions usually are accompanied by significant amount of coelocytosis, indicating their HPV origin. As the lesions progress to vein 2, they exhibit a thicker aceto-white epithelium, a more raised external border, and less iodine uptake. When vein 3 occurs, the surface may be more papillary, and the vascular patterns of punctuations and mosaic may occur. Early invasion is typified by vascular patterns similar to those of the cervix. Intraepithelial disease frequently occurs in the cervix, vagina, and vulva, and it may coexist in these areas. The cause and epidemiological basis are common to all three locations, and the treatment typically is ablative and could also be conservative. Early diagnosis and management are essential to prevent disease from progressing to invasive cancer. Women with high seal are usually asymptomatic, and the majority are aged over 60 years. High seal can be seen in younger women, especially in the immunocompromised individuals. Patients that have human immunodeficiency virus infection, or patients that had transplants of organs. Colposcopy with acetic acid or local iodine is indicated if a woman has an abnormal vaginal cytological smear and no gross abnormality. Biopsies of colposcopically abnormal areas. These are aceto-white areas with punctuations or punctuation and mosaicism is essential for diagnosis. The risk of progression of high seal to invasive cancer has been found to range between 2 and 12%. It's quite large. Treatment of precancerous lesions of the vagina must be individualized. Biopsy-proven low seal lesions can be followed up with observations. Repeat smear, colposcopy, especially if the women have non-oncogenic strains of the human papillomavirus infection. But like all things, the prevention can be divided into primary, secondary, and tertiary. As with all premalignant cervical lesion and carcinoma of the cervix and persistent human papillomavirus infection, particularly the HPV-16 subtype, has been associated with long-term development of high-grade squamous epithelial lesion and carcinoma of the vagina. The introduction of HPV vaccination as a primary preventive strategy in cervical cancer has also been shown to reduce the prevalence of the non-cervical premalignant lesions among vaccinated women. In secondary prevention, which is screening, there is no evidence to indicate routine screening. However, if a hysterectomy has been performed for persistent high seal after repeated excisional procedures of the cervix, Vol smears are recommended for long-term follow-up. In those cases where screening for vaginal cancer is indicated, the human papillomavirus test adequately correlates with cytological findings. Independent of that, co-testing seems to offer better accuracy in the diagnosis of recurrent disease as observed during the follow-up after treatment of premalignant cervical lesions. Tertiary prevention. A common etiology now we know is shared with other lower genital tract cancers, and that is the persistence of high-risk oncogenic human papillomavirus infections. Co-factors include immunosuppression and cigarette smoking. Smoking in combination with high-risk HPV increases the risk of progression to vaginal high cell when compared with non-smokers. After sampling to rule out invasive disease, vein-3 lesions must be treated. Patients with vaginal Intra Epithelia neoplasia 1 and possibly 2 and HPV infection do not require treatment. These lesions often regress, they are multifocal and recur quickly when treated with ablative therapy. However, the various modalities for the treatment of vein-3 lesions include laser ablation, surgical excision, topical treatments such as imiquimod, and topical chemotherapy with 5-fluorouracil. Choice of treatment depends on number and location of lesions and the degree of suspicion for an invasive cancer, as well as the availability of various treatment options, cost of treatment, and skill of the treating doctor. Surgical excision, for example, has the advantage that it provides a pathological description of the tissue removed, especially when there's a suspicion of a microinvasion on post-public examination. Most high cell are in the vault or upper third of the vagina, and excision is ideal in this situation. Morbidity can be associated with proximity of structures such as the bladder, the rectum, as well as the associated dyspareunia as a result of vaginal shortening and stenosis. Women should be extensively counseled pre-operatively. Carbon dioxide laser vaporization is an alternative option to excision, especially for multifocal lesions. Since there is no histological specimen with this procedure, it is imperative to ensure that there is no concern regarding cancer. Topical 5-fluorouracil, on the other hand, has been used in an effort to avoid the multi-layered adverse effects of excision and laser ablation. A retrospective study reviews recurrence rate in 576 women treated with topical 5 excision or laser ablation. Statistically significant factors that contributed to recurrence and progression were the presence of the high-risk HPV positivity and treatment modality. Laser and excision were found to be superior to topical management with 5FV in reducing recurrences. It also found that laser was more effective than excision in reducing recurrences of multifocal lesions, where surgical excision was preferable with unifocal high cell. Topical 5% imiquimod. Imiquimod can be applied topically in creams or drug-embedded tampons. Studies on these are few, but a recent randomized study trial, as well as systemic review and meta-analysis, including random systemized trial, found that this is effective and effective treatment, with regression rates similar to laser. HPV clearance rates were greater than 50%, which was superior to laser. In general, independent of choosing therapy, most patients require more than one therapy for adequate control. Since recurrence rate is high with any single therapy, close and extended follow-up is recommended in all cases. As in treated premalignant cervical lesions, both HPV testing and cytology are recommended for this women. The human papillomavirus vagina Intra Epithelia neoplasia grade 1 has spicules. This is an image of it with partial uptake of glucosidase. And the vagina Intra Epithelia neoplasia grade 2 is another image that is up here. These are references: Vigo Cancer Report 2018, Beric and Gynecology 16th edition of PDF. Thank you for listening.